في ويبينار اليوم الخاص بالصيدله. معانا المودريتور الدكتور محمد بلتاجي، هو رئيس قسم الصيدله في مستشفى السعودي الالماني المدينه المنوره. تفضل دكتور.
السلام عليكم جميعا. We'll start with first talk of دكتورة إيمان السيد يونس. She is a PharmD, BS with added qualification in cardiology, working in Saudi German Hospital Medina as a senior clinical pharmacist and antibiotic stewardship drug expert. She is a senior clinical pharmacist from Saudi Commission for health specialties. She earned Doctor of Clinical Pharmacy on 2006 and Baccalaureate of Pharmaceutical Science on 2001 from Alexandria University, Egypt. She got board certified pharmacotherapy specialist on 2012, recertified on 2019, and board certified with added qualification in cardiology on 2013. She was a speaker in many international conferences and peer review for many scientific journals and book chapters. Welcome, Dr. Iman, and you can start, please.
Thank you, Dr. Muhammad. Thanks, everyone, for your attendance. Assalamu alaikum. Good evening, everyone. I have the pleasure to represent this important topic today. I'm going to talk about the therapeutic option for COVID-19. This is my disclosure. By the end of this lecture, you will be able to know the medication options for COVID-19 and to identify the dosing regimen, adverse event, and drug-drug interaction for these medications. Since the flu pandemic of 1918, the pandemic of COVID-19 represents the major global public health crisis for this generation. Coronavirus disease or COVID-19 caused from virus severe acute respiratory syndrome coronavirus. Actually, all people with all ages have the risk for infection and for severe disease. However, there is some high-risk individual may have a high risk for fatal disease, especially elderly people more than 65 years old, and those who are living in long-term care facilities. Any individual with any age having any comorbidities, especially those uncontrolled, like in case of diabetic patient, hypertension, renal, cardiac, cancer, and with respiratory disease. Actually, the spectrum of illness of COVID-19 ranging from asymptomatic to severe pneumonia with acute respiratory distress syndrome and even death. The most important laboratory finding for COVID-19, leukopenia and lymphopenia, elevation in liver enzymes and C-reactive protein, D-dimer, ferritin, and lactate dehydrogenase. Now we have to ask a question. Have any medical therapy been definitely shown to improve outcome in COVID-19? Actually, no evidence until now that show an effectiveness of medication that improves the outcome for patients. And all of the data that we have from either observational clinical trials or non-randomized clinical trials that have high risk of bias and also contain a few number of people, not more than 250 patients, and this also introduced that is underpowered. So we believe that no medication yet, no vaccine, no prophylaxis, but we will discuss the medication that optional, under investigation, still debatable, and we will go through and enumerate the studies that show some effectiveness or not. We will go through antiviral, interleukin-6 inhibitor, corticosteroid, anticoagulation, vitamins, and the debates regarding using of ACE inhibitors and ARBs, non-steroidal anti-inflammatory drugs, nebulized medication, antibiotics, and antifungal. During the next slides, we will answer the following question. Should hydroxychloroquine or Plaquenil and or azithromycin be prescribed for patients with severe symptoms of COVID-19? This is the most commonly used combination. The second, should we advise to stop ARBs and those of high risk for severe illness from COVID-19? And finally, what is the role of immunomodulatory drugs in the management of COVID-19? We will start with antiviral. The first one, the most commonly used medication for all COVID-19 suspected or confirmed cases worldwide, chloroquine and hydroxychloroquine or Plaquenil. Actually, we have a long history of using these two medications. It's well-known, well-tolerated, generally safe medication during use of malaria and systemic lupus and rheumatoid arthritis. This is a mechanism that shared recently in a study for pharmacological treatment for coronavirus disease 2019 regarding the sites of action of potential drug target. For chloroquine and the hydroxychloroquine mechanism of action, simply it inhibits the viral entry and endocytosis by multiple mechanisms, as well as host immunomodulatory effects. So the action through either inhibit the entry or immunomodulatory effect. Both medications have in vitro activity against coronavirus. It's well-known pharmacokinetics and toxicity profile from the extensive previous use for malaria and inflammatory disease, but still limited data to support either efficacy or safety in management of COVID-19. Both medication included in the Chinese guidelines for treatment of COVID, but for NIH treatment guideline and ITSA guideline, both did not support using. Actually, they mentioned that they have no evidence either to use or to against use of hydroxychloroquine. Because of this mechanism of action, there is a theoretical mechanism that these two medications could be used in prophylaxis, and actually this medication is mentioned in some protocols worldwide for prophylaxis for healthcare workers. But until now, currently no recommendation to any agent, even hydroxychloroquine, for pre-exposure or post-exposure prophylaxis for COVID-19 outside the clinical trial. So we have no data for the effectiveness or safety to recommend using for prophylaxis. Regarding the dosing, for hydroxychloroquine, actually there is many various dosing regimen used in the clinical trials, about 6 dosing regimen. For the dose and the duration, both optimal dose and dosage and duration still unknown. But there is one study for hydroxychloroquine and for a study for this pharmacokinetic that the optimal dose may be to start with loading dose 400 milligram every 2 hours, followed for only first day, and to follow with to be followed with 200 milligram twice daily for 5 to 7 days or up to 10 days. And this is actually in the Ministry of Health protocol in KSA. For the chloroquine, the dose suggested or studied for 500 milligram every 12 to 24 hours for 5 to 10 days. Generally, the two medication is well tolerated, could be considered in pregnancy, considered safe. G6PD screening is required. and should not be given if the patient is positive. For hydroxychloroquine or plaquenil, no renal or hepatic dose adjustment needed. For chloroquine, there is a renal dose adjustment. Plaquenil could be crushed by practice, and the bioavailability will not affect it. The important thing that we need to discuss here is that some rare but serious side effects for post-medication regarding QT prolongation. So a basic ECG should be done for every patient before starting any of those medication. And there is daily electrolytes. For ECG, it should be if more than 450 to 500 to make daily ECG and to follow up the electrolyte. Another concern regarding hypoglycemia, especially for the diabetic patient on insulin, that the insulin requirement may be decreased when using hydroxychloroquine. And another neuropsychiatric effect or retinopathy, but this usually with long-term use in malaria, not with short-term use in case of COVID-19. The FDA aware that there is a report of ventricular arrhythmia after using hydroxychloroquine or chloroquine for COVID-19. So recently, few days ago, there is alert from FDA to be cautious and not to use post-medication outside hospital or clinical trial due to the risk of heart rhythm problem. And this will not affect the previous approval for malaria and lupus and rheumatoid arthritis. American College of Cardiology, they make a risk score for drug associated with QT prolongation. The risk factor for elderly patient, female 6, when using loop diuretics that may affect the electrolytes, if there is hypokalemia, the basic QTc more than 450 in case of acute MI, if using any combined medication that already have risk of QT prolongation in case of sepsis, heart failure. And this risk score give points to this risk factor and result for patient to know if it's low risk, moderate risk, and high risk. Another alert from ISMP regarding one patient who developed QT prolongation and cardiac arrest after taking hydroxychloroquine right after discontinuation of azithromycin. All of this alert just will raise our attention that monitoring of QT prolongation for the patient on hydroxychloroquine or chloroquine to monitor the ECG and electrolytes. Regarding azithromycin, which is combined with hydroxychloroquine in many patients, the most common combination for COVID patient, azithromycin, as we know, it's antibacterial, but actually it have some in vitro activity against some virus, also immunomodulatory and anti-inflammatory effect. That's why it's adjunctive therapy in the management of certain respiratory conditions like exacerbation for COPD, for the antibacterial and the anti-inflammatory effect. The second medication for antiviral and the most common medication also is lopinavir-ritonavir combination and the brand name Calitra. Each tablet contains 200 over 50 milligram. The dosing is 200 is 2 tablets twice daily, so 400 over 100 milligram twice daily for 10 to 14 days, up to 14 days. This medication have a lot of drug-drug interaction and should be avoid co-administration with some drugs that highly dependent on cytochrome 3A, either inducers. Patient with renal or hepatic impairment, no adjustment needed, although in severe renal impairment not studied, but there is some cases studied that it's used on patient on dialysis and there is a good bioavailability. Calitra could be used in pregnancy. For the EDR, the most common adverse drug effect for Calitra is gastrointestinal intolerance and diarrhea. And actually for the COVID symptoms also diarrhea. So most of the patient already have a severe diarrhea. Major side effect and not common like pancreatitis, hepatotoxicity, cardiac conduction. So we need to monitor pancreatic enzymes and liver function tests. One important point regarding administration of Calitra, I want to raise attention because it's not included in many protocols, maybe not known by many of the users. Manufacturer that does not recommend crushing of a tablet. We have two formulations for Calitra, tablet and oral solution. Regarding oral solution, it's not available in many countries, included Saudi Arabia, and also it's contain alcohol, and this will make us not use in all patients like pregnant could not be used because of this alcohol content. Regarding the tablet, the dose as we agreed is 400 over 100 twice daily. There is one study done previously regarding pharmacokinetics of lopinavir, ritonavir when crushed versus all tablet. And actually this study show a decrease of bioavailability of both ritonavir and lopinavir when crushed and giving through the NGT by more than 45%. This study actually recommend to increase the dose and therapeutic drug monitoring for Calitra. This medication, so we advise to double the dose of the lopinavir, ritonavir. Second, antiviral, omifinavir or arbidol. It's a broad spectrum antiviral approved in Russia and China. Limited data to support its use. It's previously approved for antiviral for influenza, so the same dose used under investigation, 200 milligram every 8 hours. Baloxavir, no data still for efficacy and safety, but there is 2 randomized clinical trial registered in China. Still no data to support its use, all under investigation in clinical trials. Favipiravir or Avigan, it's a broad spectrum antiviral licensed in Japan and China for treatment of influenza. It have a vitro activity against SARS-CoV, but with high concentration. It's a teratogenic, should not be used by pregnant. Generally well tolerated with mild adverse event. Now we will discuss Remdesivir. Actually, all of us received recently last week regarding the emergency use approval of FDA for emergency use authorization for using Remdesivir for COVID. This emergency use, not full approval, but at least they agree to use it under emergency use. It's a broad spectrum antiviral. There is an in vitro evidence against COVID-19. First, it's approved and was promising in treatment of Ebola, and there is successful case reports for COVID-19 management. It's investigational drug. The dosing under investigation, loading dose 200 milligram followed by 100 milligram every 24 hours, and this medication given through IV infusion. Now for Oseltamivir, it's a Tamiflu. It's a very common medication for antiviral, neuroaminidase inhibitor, again antiviral against influenza virus. The dosage used for influenza 75 milligram twice daily. Actually, if we revise the clinical trials for COVID in China, we will find most of these trials, all patients received Tamiflu. But this happened actually because this the COVID is actually appeared during the flu season, for which all all the patients when have any viral infection, they will receive Tamiflu. But until now, no data to support its use in COVID-19 and no documented in vitro activity for COVID-19. I will say one point regarding patient with suspected COVID. As we know, some of the symptoms may be similar to H1N1 or MERS-CoV. So it's common that the patient given Oseltamivir, but when he confirmed with COVID, usually the physician discontinue Tamiflu and start another options. I mean, it may be given we consider case also suspected H1N1 or MERS-CoV. Now to the second part, the anticoagulation. Patient with COVID actually have a coagulation, high risk for coagulation abnormalities, high fibrinogen, DIC, venous thromboembolism, elevated D-dimer, pulmonary microvascular thrombosis. So patients with severe COVID-19 have hypercoagulable state which lead to poor outcome. So early anticoagulation will reduce the thrombotic complication and will improve the outcome of the patient. The recommendation from International Society of Thrombosis and Hemostasis and the American Society of Hematology that all hospitalized COVID-19 patients, including non-ICU patients, should receive a prophylactic dose of low molecular weight heparin unless contraindication. This contraindication generally for anticoagulant like severe bleeding, severe thrombocytopenia or active bleeding. Heparin will be used in case of renal patient. NHS actually released a very nice table regarding the dosing of enoxaparin for COVID patient. And this table depends on the D-dimer and patient weight. So if the D-dimer is less than 1, the dosing will be depend on the patient weight. We will start with enoxaparin 40 once daily if the patient less than 100, twice daily if more than 100 to 150, and 60 BID if more than 150. If the D-dimer more than 1, so enoxaparin will be 40 BID, then for more than 180 BID, and maybe until 120 BID. The important thing that D-dimer monitor is very important for patient either suspected or confirmed, because D-dimer may be low in the beginning, then increase. So we need all the time to manage the anticoagulant dose. Now we will go to the part regarding interleukin-6 antagonist. And I'm happy to represent also our experience in Saudi German Hospital, Medina, in this part. Interleukin-6 antagonist, this medication named tocilizumab, trade name Actemra. Tocilizumab bind to interleukin-6 receptor and prevent activation. As we can see from this mechanism, here's the receptor. If bind to interleukin-6. Okay. We'll talk about interleukin-6 and cytokine storm. Interleukin-6 is a pro-inflammatory cytokine. It's a mediator during inflammation. So the elevation in interleukin-6 level will happen in severe systemic inflammatory response in COVID patient. So after this inflammation process, there will be high release of cytokines, which will known with cytokine storm. And this will have a complication for cardiac toxicity and may lead to death. For the tocilizumab, it's a disease-modifying anti-rheumatic drug, monoclonal antibody specific for interleukin-6 receptor. This medication will treat severely critical cases of COVID-19 patient with extensive lung lesion and high interleukin-6 level. Patient demonstrated rapid fever reduction and a reduced need for supplemental oxygen. From our experience in Saudi German Hospital, Medina, in ICU, for patient using tocilizumab, there is a good outcome. The dosing, this is IV medication, initially 400 milligram IV infusion, usually the dose from 4 to 8 milligram per kg. The maximum single dose is 8 milligram. We can repeat only one single time if needed after 12 hours. Adverse drug effects, increasing in liver enzymes, neutropenia or thrombocytopenia uncommon, high risk for serious infection like tuberculosis, but this only in continuous dosing for other indications. With the same point of view, using corticosteroids, there is a debate for using corticosteroids. With the same mechanism, like it's anti-inflammatory, it will decrease the elevation of cytokine, so it theoretically can help during the COVID-19. We will use our previous experience with influenza and other coronavirus may be relevant. There is a recent Cochrane analysis of influenza pneumonia demonstrated that using corticosteroid may increase mortality and incidence of healthcare associated pneumonia, and also will make a delay in viral clearance. So routine use are not recommended. Okay, and this also from the Surviving Sepsis campaign, recent guidelines for COVID-19, if there is no ARDS. In case of mechanically ventilated adult with COVID-19 and ARDS, still insufficient data either to recommend or to suggest against, but it's preferred if the patient with COVID-19 have a refractory shock. So low dose corticosteroid is preferred over no corticosteroid use. Now we will go to the debates regarding using ACE inhibitor or angiotensin receptor blockers or not. Now in this mechanism for SARS-CoV virus bind to ACE inhibitor receptor. So the virus uses this receptor to complete the life cycle. Because ACE inhibitor and the ARBs already bind to ACE inhibitor in the patient, in patients that already on those medication. So we have two theory, harm theory that suggested maybe the patient who already on ACE inhibitor or ARBs, there is overexpression of these receptors, so it will be increase the risk of infection. And another theory, benefit theory, that these receptors already blocked by the ACE or ARBs. It will maybe make a benefit that it will prevent the infection. Till now, no complete data, but American Heart Association, American College of Cardiology, Heart Failure Society of America, European Society of Cardiology, all recommend against discontinuing medication in patient already used either ACE or ARBs, especially in those patients with heart failure, with low ejection fraction, and really in need for this medication. Ibuprofen, or generally non-steroidal anti-inflammatory, ibuprofen used in some clinical trial, and there is also theoretical that it may increase ACE inhibitor expression, angiotensin converting enzyme expression, and there is FDA know that all label of non-steroidal anti-inflammatory that warn that by reducing inflammation, it may diminish the diagnostic signs of infection. So the Surviving Sepsis campaign COVID-19 guideline prefer to use paracetamol for temperature control over no treatment. But till now, there is no recommendation not to use non-steroidal anti-inflammatory, and if needed, should be used by lower doses and for the minimum duration, and of course monitor the patient. Regarding nebulized drug for management of respiratory symptoms for COVID patient, actually the recommendation, it may cause potential harm for healthcare worker or generally for any individual in contact, because it will release the aerosols, and this will increase the risk of infection. So it's replaced by meter dose inhaler or not preferred to use. Regarding prophylaxis, as we mentioned previously, at present, no agent is known to be effective for either pre-exposure prophylaxis or post-exposure prophylaxis for COVID-19. There is some agent under clinical trials: hydroxychloroquine, plaquenil, chloroquine, or lopinavir, ritonavir. Regarding using of antibiotics, as we know, the patients with COVID-19, sometimes when admission, there is signs and symptoms, maybe there is a pneumonia, and there is the same signs with community-acquired pneumonia, so we have to follow our protocols. Also, there's high % of patients already, they will develop a bacterial infection after viral infection. Although the recommendation is, there is insufficient data to recommend the empiric broad spectrum antimicrobial therapy in absence of other indication. But from our experience, we suggest if there is any signs for pneumonia, we will follow our protocol and we will monitor the patient for management of healthcare associated pneumonia, and generally we'll monitor the patient. We can also follow the results of the culture, and we can also de-escalate as soon as possible. Now, many data regarding using of a plasma for recovered patient of COVID in infected patient, and now there is many clinical trials going on regarding use, but still no evidence for using. Regarding nutrition and supplementation, generally multivitamins will increase the immunity. This is number one. Second, there is some data previously regarding some vitamins like vitamin B in MERS-CoV and ventilator-induced lung injury, for vitamin C, for zinc in case of SARS-CoV and measles, for iron. So we suggest that we can use some of this nutritional intervention to increase patient resistance to infection, especially vitamin B, zinc, and iron. Now, at the end, we will go to our conclusion. No approved treatment for COVID-19 yet. Treatment option should be individualized according to patient condition. This is a very important point, because as many things will guide us: patient condition, availability of the medication, response, side effect for the medication. Remdesivir have got emergency use authorization from FDA recently. All hospitalized COVID-19 patients should receive prophylactic dose low molecular weight heparin unless contraindicated. We should monitor the D-dimer. Also, we should have an accurate data for patient weight. All treatment data to date derived from observational data or small clinical trials introducing high risk of bias and also low power. Many clinical trials launched to investigate potential therapy for COVID-19. Now, more than 300 clinical trials are launched, and we expected the results soon, inshallah. This is the reference. The important thing that just I need to raise regarding experience in Saudi German Hospital Medina. There is important points. First of all, because these medications may be not common for every healthcare worker, the huge number of patients may be suspected or confirmed. So we need really a drug interaction checker active, should be done for every patient, because we will find many of the drug interactions with medications that maybe we don't have experience before. So we should monitor this. The second thing that my suggestion, and we did this in South German Hospital, that we should have our own protocol in ICU and in wards also. Now the world or hospital worldwide, they receive many patients for COVID, confirmed or suspected. They will deal with different patients with many medication. Sometimes patient discharged from ICU to ward, either to continue medication or to stop some antiviral medication like Calitra up to 14 days only, for Glacanil up to 10 days. So we need to really make it in like a checklist or a protocol to help physician to monitor the labs also for this patient. So regarding to make our own protocol, also for using the antibiotic for the duration of antiviral, for the lab results monitoring. Thank you. Now we will go to
Thank you very much يا دكتورة.
شكرا دكتور. شكرا.
Thank you very much. جزاكم الله خير. We have بس first of all طبعا thank you for Dr. Iman for this fruitful topics for the COVID-19 pharmacotherapy. We have some question from the audience. Number one يا دكتور. لسه ما كملتش يا دكتور إيمان؟
Last 3 questions. Okay. Just to check if the audience are with us on the same line. The first one, the US FDA issued an emergency use authorization for one drug to treat suspected or confirmed COVID-19 in adults and children hospitalized with severe disease. Which one from the following got this emergency use authorization for use? Remdesivir, Lopinavir, Ritonavir, Ribavirin, or hydroxychloroquine? We just mentioned this in the last part. If we have answer from the audience, I think most of our audience, if they follow the lecture, the answer is number 1, Remdesivir is the medication who got the emergency use authorization. The second question, QTC prolongation occur in many case reports during COVID-19 management with which combination of medication? Hydroxychloroquine with Lopinavir, Ritonavir, hydroxychloroquine with azithromycin, hydroxychloroquine with tocilizumab, or azithromycin with tocilizumab. We got answers? The most common combination, yes, it's hydroxychloroquine plus azithromycin. The third and last question, which medication from the following that doubling the dose could be considered when crushed and administered via nasogastric tube? Hydroxychloroquine, Remdesivir, Lopinavir, Ritonavir, or tocilizumab? I hope that everyone got this point, because it will not appear in many protocols or guidelines. Yes, it's Lopinavir, Ritonavir, Calitra. the bioavailability decreased by more than 45% when crushed and used via NGT. So we recommend to double the dose. Thank you.
Thank you دكتورة إيمان. Thank you very much. جزاكم الله خير. في بعض الأسئلة, some question from the audience. I will tell you. They ask about the IVIG. Is this in our protocol we can use, or what is the role of IVIG in COVID-19 pharmacotherapy? This may be audience or three audience ask this question.
Actually, IVIG going with the same line like corticosteroids and interleukin-6 inhibitor. I mean the same mechanism that decreasing the inflammation or immune modulatory.
يا دكتورة إيمان الصوت واضح ولا إيه؟ كان في مشكلة في الصوت.
السلام عليكم.
كان في مشكلة في الصوت. كده تمام. خلاص السؤال بتاع الاي في اي جي خلاص. أنا ما كنتش معاكم معلش. سامعاني؟
أيوه.
في سؤال تاني بيسأل بعض الاودينس. Some audience ask about the challenges of supply chain for medication availability. في 2 أو 3 سألوا السؤال ده، فأنا هجاوب عليه بعد إذنك. طبعا we face some challenges in availability of COVID-19 medication like الهيدروكسيكلوروكوين or الانتيفيرال or even الانتيبيوتيك اللي هو الازيثروميسين. We face some challenges and from the management decision we increase our stock from يعني stock turnover from 2 months up to 6 months in this crisis to be able to overcome this crisis. For sure we will face some challenges even or as some medications are coming from outside Saudi Arabia. So we take a decision to increase our stock turnover from 2 months up to 6 months. I hope all hospitals to make like this. Another question, Dr. Iman, about Remdesivir. Any comment about this antiviral medication? Again, معلش.
أيوة دكتور. Remdesivir. Yes, Remdesivir. Maybe all will talk about this medication because it's just received authorization from FDA, but it's not fully approved, not got full approved, just for emergency use. Actually, there is some data that it's promising data, case reports that there is a good outcome for patients who receive this Remdesivir. We hope that will be available so we can have our own experience for this medication.
تمام. في سؤال تاني بقى عن الناس بتسأل. Many audience ask about our protocols is like MOH protocols or different. So please give us a brief about our protocol or about MOH in Saudi Arabia protocols, because some audience from outside is asking about this question.
Yes. Actually, the protocol of MOH is very good and full. But I mean, generally, for our own protocol, this make guide for many things. As I mentioned, that there is many patients now with the same indication, either confirmed or suspected. I mean, simple protocol straightforward, make an easy guide like a checklist. What is the lab what's the lab should be done, should be monitored. What is the duration for the medication? Maybe MOH mentioned this from 5 to 7 days. Maybe this for Plaquenil, it's up to 10 days. I mean, if we make our own protocol by agreement of all physician or pharmacist or any healthcare worker included, it will make standardized our protocol and management. It will improve the patient outcome, improve the safety, decrease any missed medication or because now, as we know, many patients with COVID-19 and the medication also may be new for many of healthcare workers, like protease inhibitor. So if we can make a simple protocol like lab results, like dosing for medication, duration, any suggestion like criteria when I should use interleukin 6 inhibitor, it will really help. And this based on our experience. If audience like, we can make this in separate webinar. I would be happy to share this, inshallah.
شكرا دكتور ايمان، جزاكم الله خير. ثانك يو فيري ماتش. في سؤال للاستاذ علاء بقى، بيسالوا على عدد الساعات يا استاذ علاء، و how many CME hours and how we can go to it يعني.
Inshallah, for all the participants, they will have CME hour, but now there is a new protocol in Saudi committee. So inshallah, within the next week, inshallah, they will have the CME hour, inshallah. And also anyone who want to take attendance certificate, please connect with us on the email, and inshallah we'll send attendance certificate to them. And kindly, from all the participants, the participants that with us, you will receive evaluation email. Kindly fill it and send it to us. This will help us to improve ourselves and to be better in our webinars. Thank you, Doctor.
شكرا استاذ علاء. Next topic will be with Dr. Dina Kamal, which is medication reconciliation in COVID-19. Dr. Dina Kamal is a CBHQ, TQM diploma, working in Saudi German Hospital Medina as a medication safety officer, quality improvement pharmacist, and antibiotic stewardship coordinator, baccalaureate of pharmaceutical science since 2007. She got total quality management on 2014. She got certified board of healthcare quality on March 2015 and recertified at 2018. She got a certificate on antimicrobial stewardship on 2019. Please, Dr. Dina, to start.
السلام عليكم جميعا. Thank you for Dr. Biltagi. Today, inshallah, I will start with you with the medication reconciliation for COVID-19. Before I will start my presentation, I will give you some questions and then I will give you the answer during my presentation. Do you think the medication reconciliation useful or not? This is from your side. This is yes or no? What medication should be included in the best possible medication history? This is prescribed drugs or non-prescribed drugs, IV solution and natural supplements, prescribed and non-prescribed drugs. When should the PPMH, this is best possible medication history, be obtained on admission? Within 12 hours or within 24 hours, within 48 hours? The answer will be, inshallah, in the lecture. Learning objectives of these lectures is, no, what is the medication reconciliation? Why we make medication reconciliation? When we can do medication reconciliation? Who can do medication reconciliation? How can we do medication reconciliation? What is the importance of medication reconciliation for COVID-19? Why do we need medication reconciliation for COVID-19 patients? Let us start with the definition of medication reconciliation. It is a formal process in which healthcare providers work together, patients and families, care providers, to ensure accurate and comprehensive medication information and communicated consistently across transition of care. So, the process of creating the most accurate list of medication at all transition points. The goal is with providing correct medication for patients, for all patients, and the COVID-19 also. This is our target here in lectures. Medication reconciliation requirements a systematic, comprehensive review of all the patient medication is taken, which is known as best possible medication history, to ensure that the medication being added, changed, or discontinued are carefully evaluated. The importance of medication reconciliation to prevent medication errors. This is one during therapeutic duplication for the patient, omission dose, unnecessary dose, decrease the adverse drug events. This is especially by clinical pharmacists, decrease the long-term care, improve the communication. This is by working together with all healthcare providers, between all staff members, to collect best information, medical history of the patient which coming for the hospital, and improve teamwork to get or improve patient safety. What is the impact of medication reconciliation? The medication reconciliation process is a cost-effective strategy to reduce medication discrepancies and potential adverse drug events as a patient moves through interface of care. Also, there is evidence that a successful medication reconciliation process can reduce workload and rework associated with patient medication management. When we can make a medication reconciliation good for all patients or any of this, lead to decrease the workload for all staff. Let us answer this question. Who should obtain the best possible medication history? Not only physician, no, we can do by nurse, pharmacist, whose scope of practice including this activity, and they can receive training of how he can create best possible medication history, and they can follow a systematic process of such a best possible medication history interview. The one who can make a good interview with patient or the relative with this patient who the doctor who already decided to admit the patient in the organization or hospital, and give a lot of information, best information from him. He is the one to be fulfill the best possible medication history for. When we can do the medication reconciliation. This is, we can do it at all transition points. We can do it on admission, when the patient transfer in the hospital from ward to ward, or from doctor decide to make for him operation, or from the doctor decide to discharge the patient. Let us know what is the goal of medication reconciliation on admission. The goal of this medication reconciliation on this stage is to ensure that there is clear communication about decision, what is the prescriber make to continue, if the doctor decide to continue any medication or decided to discontinue or modify any medication regimen upon admission on the patient has been taken prior to admission. This data already collected after we get PPMH. When we already start medication reconciliation on admission, this is building case. What medication should be included in PPMH? The medication should be included in the PPMH is prescribed drugs and the non-prescribed drugs. All medications that patients receive over the counter that medications received, also vitamins and the natural health products. In this case, the organization must put policy and procedures for this stage and must already put this policy and procedure clear for all stuff that they already put the form of PPMH to be clear, and including what already should be in the form and must be IV fluids and minerals and supplement natural, not be already in the PPMH. Building case, how we can do. Once the doctor or physician started to admit the patient, the PPMH will be completed as soon as possible. This is from the patient or from his relative. If the patient comes to the hospital unconscious, this is in case also in the COVID patient. We will, after that, discuss in details. The entire medication reconciliation process should be completed within 24 hours from the time of decision of admission. Document, this is the very important stage, and medication received by patient. How can we do medication reconciliation? This is 4 steps to make good medication reconciliation. The first step is verification. From where we can make verification, this is from the patient. This is the first step. Verification, we can collect an accurate medication history. We can make a verification from the patient if the patient becomes conscious for the hospital, or from the relative if the patient becomes unconscious. Second, we can make clarification. Clarification ensuring that the medications and the dose can appropriate. Here in this stage, the role of pharmacist and the nurse is very important, that they can do a lot of work. In this stage, they make appropriateness for medication, and this is the role of nurse and neuropharmacist. Medication reconciliation, the third step here is reconciliation, to document medication change. You see this picture here, this is 2 persons, and this is number 6. From each side, for one reads this picture 6, and the other reads this picture 9. So it must be document medication change. Reasons for change, temporary or chronic. If the doctor already here in this stage decided to change this medication to decrease or increase the medication dose or discontinue, we must know this is temporary or chronic. Transmission, this is the last step. The updated and verified list is communicated to the next provider of care. Medication reconciliation at transfer. In this stage, transfer is an interface of care. However, orders need to be reviewed and rewritten according to facility policy. This may include change is responsible medical service or changes in the level of care, post or pre-operative, or transfer between units. When the patient become better or the patient transfer from ward to pre or post-operative, there is another order. In this case, we must make reconciliation. So, how can we do reconciliation at transfer? Compare the admission, PPMH, best possible medication history. Compare this form with the transfer orders, the new order for the patient, with the existing transferring units medication administration record, ensuring all medications have been assigned. Identify and resolve the discrepancies with the prescribed. Also, the most important to document and communicate any resulting change to the medication orders. The last thing here is to reconciliation of discharge. When the doctor started to make discharge order for the patient, we must make reconciliation for discharge. I think in the all organizations, this is not applied, but this is very important process. What is the goal of the medication reconciliation at discharge? The goal is to reconcile the medications the patient is taken prior to admission. The medications that already the patient received before admission, and the medications that already received during the patient, which already in medication administration record. With the medication, they should be taken post-discharge. This is one. Another, to be ensured all changes and intentional and that all discrepancies and resolved prior to discharge result in avoidance of therapeutic duplication, omission, unnecessary medication, and confused. How can we make reconciliation at discharge? Reconciliation at discharge, this is create PPMDP. What is this? Best possible medication discharge plan. When the doctor will make discharge paper for the patient, he will put a plan for the patient. This is a plan for patient. How? By review. Must be by review. What is the medication of the patient before admission, and what is the patient medication that he received already during the admission and during transfer, and compare these medications already that he received in the medication administration record, then write a new order for the patient. This is mean best possible medication discharge plan. After that, identify all discrepancies between PPMH, it means best possible medication history, and medication administration record. Resolve and document all discrepancies with prescriber. If there is some discrepancies or some difference between PPMH and MER, this is medication administration record and best possible medication history. if there is any discrepancies or this is different in the dose or omission dose or duplication therapeutic dose, this must be documented and solved with the prescriber. After that, communication discharge plan to the patient and next provider. There is a lot of roles and responsibilities for pharmacists in reconciliation. Let us show what is the role of pharmacist. The pharmacist has a lot of function. The main fundamental function here is developmental policy and procedures. This is who creates the policy and procedures. This is with organizations, and development of policy and procedures. This is the role of pharmacist. Implementation and performance improvement. This is the role of pharmacist. Training and the competency assurance. Information system developments, advocacy. Responsibilities also providing leadership in designing and managing the patient-centered medication reconciliation system, education of patient and healthcare professionals about the benefits and limitation of the medication reconciliation process, reduce the frequency and severity of hospital medication errors, decrease the rate of drug-drug interaction, mainly this role for clinical pharmacists. The role of nurse in medication reconciliation, they play an important role with patient in medication reconciliation. I think this is the first point of contact between patients and healthcare team, involved in the collection of verification of best possible medication history, provide education for the patient about their medications, advocate their needs, communication link between the patient, family, and members of the healthcare. The medication reconciliation, there is a relationship between patient counseling. Especially when we already started to talk about medication reconciliation, we must already talk about, during the discharge, we must already talk about the medication reconciliation. This is a relationship between medication reconciliation and patient counseling. How? Let us start with definition of patient counseling. Patient counseling, it is a very important process that is informing the patient about medication use, frequency, dose, side effect, drug-drug interaction, also drug-food interaction, information related to the patient, the drug, and information related to the case of the patient we need. This is the role of the pharmacist mainly, because this is the link of the between pharmacist and medication. Must be already know this is the process includes very important steps, which vary the measure outcome, increase the measure outcome of medication reconciliation, which is increase the patient safety. Our target here from medication reconciliation and patient counseling is to increase and improving the patient safety. And this is already by combination of medication reconciliation, especially in the, during the discharge and the patient counseling. Medication reconciliation with patient counseling. The counseling was aimed at gathering information about actual medication use and educating the patient. This carried out by verification step and clarification step and reconciliation and information to physician and other. Let us know verification step by using a printed schedule of the discharge pharmacotherapy medication sheet. Also, clarification step by checking the medication for appropriateness and discussing them. Drug-related problem with the patient. Reconcile the checking the new prescribed medication for the patient and information to the physician about discrepancies, quality of the pharmacotherapy, monitoring pharmacotherapy adjusted by physician, then give to the pharmacist, and after that the pharmacist started to give patient counseling and give all information related to the medication to the patient. Let us start about the very important part of our session here about medication reconciliation and COVID-19. How can we apply reconciliation with a COVID-19 patient? We will apply reconciliation with COVID-19 patient during admission, transfer, and the discharge. But here we will start to talk about chronic patient on admission. If the patient is chronic patient with hypertensive patient or diabetic patient or hemodialysis patient, this patient, a chronic patient, those patients are greater risk than others. When this patient admitted to the hospital with COVID-19, this is more risky than other patients. We must take a lot of information from them during PPMH. This is best possible medication history, and all medication must be known about them, and especially in the case if the patient already come to the hospital about hypertensive. As we know from if the patient already received medication for hypertensive as ACE inhibitors, we must know, and if the patient already not informed us, we don't know what is, and we don't know what is we will do with the patient. We must already know what is he received by medications for the hypertensive, because if he received a lot of medication and he forgot to inform us, we like ACE inhibitors. If he received ACE inhibitors, he must complete but not start a new medications. As we know about Dr. Ayman already explained a lot of medications and informed us a lot of, this is already very important thing. So for COVID-19 patient, must be take best possible medication history from this patient. Diabetic patient, hemodialysis patient, but if this patient become conscious for the hospital, this is easy for us to take a lot of history for him. But if this patient come not conscious for us, this is more difficult, and we will notice this, or if he already chronic or not chronic, from checking all things. Also, we must know if this patient already have history of drug sensitivity, especially antibiotic, and it must be already documented. And for all organization, there is a system for form of PPMH. This is or electronic or this is manual by paper, but this is preferred to be manual or computerized by CPOE, computerized physician order entry. This is easy to be shared all informations to all health workers, and this is increased team communication between them. But if there is not computerized physician order entry, this is preferred to be with medication administration report, with MAR, with the file of the patient, to be known what is, if already this patient have sensitivity of all the drug, of what is sensitivity of the drug, especially in the case of antibiotic. Here in this picture, we will know if the already patient COVID-19, we will transfer from station to station, or from ICU to ward, or will do another, or from ward to hemodialysis if this patient already chronic with hemodialysis, or from another station. This pictures show for us, this is best possible medication history. This is for on admission, and this is medication administration record. This is during admission, and this is new transfer order. It means when the doctor started to transfer patient from a station to another station or to do a new session, it must be new transfer order after making reconciliation. Reconciliation with COVID patient on transfer. Internal transfer is usually associated with change in patient status. He will do something, do another service, or he will be better, or transfer from station to another station, means a transfer from ICU to ward, or transfer from ward to operation, or transfer from ward to do hemodialysis. Transfer usually involves the use of standardized paper or computerized from CPOE, computerized physician order entry, depend on the hospital system. This is more easy if there is already on the system, because this is more easy to share information about the patient on the system, and after that it will make compare between best possible medication history and between medication administration record when during admission, and document anything if there is already discrepancies in the order, and rewrite a new order for transfer. After that, they easy communicate with all healthcare workers. Reconciliation with COVID patient on discharge. Discharge COVID-19 patient and his families, will end for home isolation. When they will go for home isolations, there is a lot of things we will do. This patient will go with home with their medications. If they are already chronic patients, they will take a lot of medications, and they will be already medications for them, and the chronic patient and medication for COVID. So they need medication for discharge. Reconciliation, we will make reconciliation by comparing medication already receiving before they come for our hospital, and comparing medication with receiving medication on hospital during admission. Check the medication already during the discharge. This is the plan, what I said before, and after that make reconciliation for them. Reconciliation in this station, in this step is very important for them, especially in COVID patients, because you will set for them a lot of things, especially they need a lot of things to know. What is they need to know? They will take this medication, antibiotic, antiviral, how many days they will take, how many doses they will receive. So hospitalized suspected or confirmed COVID patient cases will discharge medication reconciliation, clarifies the patient medication by review, best possible medication history during admission, and medication administration record, and the discharge plan medication already. And after that, they will communicate using systematic process to discharge plan medication. This will be a systematic process, and will go to for patient, physician, pharmacy, and long-term care and home care provider. After that, the best possible medication discharge plan will be explained to the patient. After that, the counseling is a very important role here for the patient, and also lifestyle, especially for COVID, because this is need to support for lifestyle. And after that, follow-up is very important here. Thank you. And if you need any question, I will inform you. But before I will finish my lecture, I will inform you something. There is 3 questions in the first lectures. Do you think medication reconciliation useful or not? we already what is the importance of medication reconciliation during our lectures. This is very important to know what is the medication that we already received. What medication should be included in the best possible medication history? The best possible medication history, it must include prescribed and non-prescribed drugs. When should the best possible medication history be obtained on the admission? It must be should as soon as possible, maximum within 24 hours. Thank you for all attendees.
Thank you, Dr. Dina, for this fruitful lecture. There is some question from audience. Repeated question. Give us brief about when necessary to make medication reconciliation. قول لنا بس الخطوات اللي بنعمل فيها medication reconciliation باختصار كده.
طيب. Medication reconciliation started when we already admit the patient, admission, and transfer and the discharge. When the patient started to come to the hospital on admission, we make a reconciliation and collect history from him, best possible medication history. This is the first step. This is make on admission. And after that, we can make medication reconciliation during the transfer. Transfer a patient from ward to ward, or when he transfer from a patient from ward or do something, hemodialysis, or from a patient to go for ward or ICU. And also we can do medication reconciliation. And when the patient will discharge, this is when we can make medication reconciliation. الخطوات when the patient admission. أول حاجة medication admission, collect the data from the patient about medication reconciliation, about best possible medication history. If the patient already admitted conscious, or patient conscious, we already collected data from him. If not conscious, من relative. And document this data on already the form of the medication sheet of the already manual according to the organization, or if the already this organization computer electronic, this is computerized. After that, document these medications and make communication with all healthcare workers and share these medications with doctors. بعد كده transfer. لو this is transfer، لو في transfer هنعمل comparing الميديكيشن البيست possible medication history مع المار الميديكيشن administration record الميديكيشن فيه. بعد ما هنعمل comparing للميديكيشن هنعمل documentation لو في discrepancies between orders، هنا هنعمل new order for transfer. الdischarge بنعمل compare للبيست possible medication plan discharge، نعمل document للdischarge للبلان، بنعمل لو في discrepancies حصل بنسجل الدوكيومنتيشن، وبنعمل نيو اوردر للديscharge اللي هي البلان الجديده. بعد البلان بنعمل كوميونيكيشن للبلان دي للدكتورز والفارماسيست، بعدها بنعمل اوردرز جديد للديscharge. بس
تمام، شكرا يا دكتوره دينا. ثانك يو فيري ماتش. في اسئله كتيره برضو للاستاذ علاء اللي بيسالوا تاني على السي ام اي اورز وهاو تو جيت سيرتيفيكيت وهاو تو جيت السي ام اي اورز، والنكست ويبينار برضو بيسالوا عن الموقع بتاع الويبينار. if there is any future webinar they need to come يعني or to register in it.
Okay, thank you, Doctor. For the CM hour, inshallah, when they register first in this webinar, we take the number, and inshallah within the next week, inshallah, we'll they will take the same hour, inshallah, for this webinar. For the certificate, attendance certificate, anyone who wants to take attendance certificate, please connect with us in the email. It's info@smartpodium.sa. This, inshallah, for the next webinar, it will be on 11th of May. This for public, not without CM hour. It's in Arabic. Name of the webinar is صحة المرأة وطفلها في زمن الكورونا. With us will be Dr. Nadia Kabli, and she's consultant from Jeddah, and Dr. Manal, she's consultant for breastfeeding, and of course our CEO, regional CEO, Dr. Ahmed Isa, to talk about the anxiety and the psychiatric part for the female and for the pregnant and also for the children. So thank you a lot, Doctor.
شكرا استاذ علاء، وشكرا لكم جميعا. ونكست ويبينار امتى يا استاذ علاء لو سمحت؟ معلش
11 ماي ان شاء الله. 11 ماي
11
ان شاء الله حنعلن عنه ان شاء الله بكل المواقع ان شاء الله الخاصه بالمستشفى. ويا ريت الله يخليكم اللي حيجيكم دحين رابط. There is a link for evaluation and for feedback. Please fill it and send it back to us, please. Thank you all.
شكرا جزيلا، جزاكم الله خير.
شكرا جزيلا. شكرا دكتورة.